you. So workforce is pretty much a priority for everyone these days. And as I mentioned earlier, our focus is for the last 30 years has been on serving the needs of the direct care workforce. And those are certified nursing assistants, home health aides, hospice aides. They have about 30 different titles, but certainly those people who have been at the epicenter of the pandemic the last couple of years. And as you know, they serve Iowans of all ages and abilities and work in all kinds of settings from in our homes to assisted living, nursing homes, hospitals, and hospices and other settings. It is a high demand workforce. And again, as you all know, it was in crisis long before COVID came along. So I'm going to provide just some background information, and then Directors Matney and Johnson will share what we view as good news, we think, to start off the new year. As many of you know, last year, House Bill 692, sponsored by Representative Bergen, and thank you again, Representative Bergen, called for the modernization of the Direct Care Worker Registry and passed the House HR Committee unanimously, but then it didn't make it to the floor for debate. And honestly, and I don't say, I mean, in some ways it's kind of funny, but I think we do hold a record for somebody that's been working on the same issue for about 15 years. And probably every legislator that's on this call has either sponsored a version of the bill or has supported it through some committee support or speaking in favor of it from the Senate or House floor. And I don't know if Senator Yoakum and Reagan are on. They were planning on joining us this morning too, but I know they both sponsored some version of the bill in the past. But it doesn't matter. We've always been grateful for whatever support we've had from both sides of the aisle. So how did we get where we are now? In 1987, federal law was passed, OBRA, the Omnibus Budget Reconciliation Act, that then required all nurse aides in nursing homes to be certified. And that meant they needed to complete a 75 clock hours of training. It also required every state to establish a registry, a nurse aide / direct care worker registry. We use those terms interchangeably here in Iowa, and the purpose of that registry was to maintain a list of certified nurse aides who were eligible to work in Iowa's nursing homes, which meant they had successfully completed the 75 hours of training, and that they also had no history of criminal history or record of abuse. So 35 years ago, that was a long time ago, and about the only options that we had for any kind of extended care were nursing homes or maybe county homes. But I think you would agree that we've come a long way since then. We have all kinds of options for people to receive care and supportive services. But unfortunately, our policies and systems and infrastructure have not kept up with the way we deliver care and supportive services. And it can be very burdensome and hampering, and especially the past 2 years during this pandemic. Yet still today, only CNAs who work in nursing homes are required to be on the registry. So we have this grossly outdated law and system. And so that was the whole intent of House Bill 692, was to bring this up to date and modernize that system. So the bill had two key components. And one was to modernize the nurse aide, direct care worker registry to be more inclusive of the caregiving community. And the benefits of that, there are many benefits, but the primary benefits are for direct care workers. It will provide them a permanent and portable credential, whatever their training is. It's a permanent record of that, and will follow them from one place to another. The state will have more accurate data, access to more accurate data on this workforce, which quite frankly, we do not have now. And if we're going to plan on how we're going to meet the needs of Iowans by ensuring that we have a stable direct care workforce, we need accurate data on how many people are working in the field, where they go, do they go on to become other licensed professionals. We do not have accurate data on this workforce. And third, we've heard from home community-based employers who say that it will help to expedite the onboarding of new employees and reduce some of that burden. The second component of the bill was to create a voluntary public portal of caregivers. And I think it's important to note here that we have not had an opportunity yet to have a very detailed conversation with Directors Matney or Garcia or Johnson about this. So I can't swear that our vision of what this public portal might be, it totally aligns with what their vision might be. I know there's a lot of work to be done, but I will share what our vision has been. And that is that all these additional workers who would be included in this modernized or updated registry could then opt in to be on this public portal of caregivers. That then could become a resource for family caregivers, people with disabilities, older Iowans, and employers. And I think it would also provide us an opportunity to grow this high demand workforce by attracting like former or retired nurse aides. And we've surveyed these people over the years, and a large percentage of them have said they would remain in the field beyond retirement if, one, we could take some of the physicality out of the work, because these are backbreaking jobs in many instances, or and pay them better. It could also attract college students. There are roles that people with disabilities could play in these professions, seasonal workers, and former family caregivers, and others. So, so those were the two components of the bill, and we're very happy that we're going to see some movement forward on this. And I see Director Matney has joined us now. Thank you so much. I know how busy you are too, but in the past year, there have been some promising steps taken that we believe is a win for workers, for employers, for consumers, and the state. And with that, I'll turn it over to you, Director Matney, so that you can share what you've included in the ARPA spending plan, and maybe what you envision moving forward, and how all of us on this call can be helpful to make sure that there's a successful implementation of what your plans are. Thank you.
Thanks, Di. What an intro. Good to be here today. Definitely important work. So earlier this year, through the American Rescue Plan, Congress set out a framework for states to receive an extra 10% federal match on their home and community-based services, so that they could use that extra federal match to put forward some strategies to expand or improve quality of care for those same HCBS services. So the state put forward a lot of ideas. We also engaged stakeholders both through an email process where they could submit ideas, as well as through a town hall process. And one of the pieces that did come through pretty loud and clear was for our HCBS waiver population. They're really seeking a place to be able to connect easily with caregivers that could come into their home. So right now, we don't have anything exactly like that. I know that, Di and Director Johnson have been working on the direct care registry, but it's my understanding right now that's pretty limited to CNAs, and the main benefactor of that registry is the facility-based population. So we just were thinking about, okay, how do we do this? Right now, those same members are struggling in finding workers, and a lot of that has to do with the perfect storm of where we are today with the workforce challenges that we hear about all the time, right? But also it has to do with the fact that we're seeing a problem in our home and community-based service landscape. It was bad before we entered the pandemic. The pandemic just made those workforce issues much more challenging. So we have our HCBS waiver members trying very hard to find caregivers in pretty creative ways. So we see them putting forward Craigslist ads. They have Facebook groups where they exchange kind of information on caregivers that, you know, one individual has found and really liked and thought, you know, they have room to be able to provide services elsewhere. So that you know, they are creative. However, this isn't the most reliable format for them to get quality providers. And like Di was mentioning earlier, when we heard this feedback, we're like, wow, this is a really great idea. And it's also a great opportunity for some of our consumer-directed attendant care providers and our consumer choice employees to be able to have that same sort of portability with their credentials, and for our HCBS members to have a place to go in a portal and see, okay, who's in my area, what kind of trainings have they received, what kind of background checks have they received, and just be more able to easily connect. So I think there's a lot to happen as far as coordination. Director Johnson, Di, and myself have to sit down and see, you know, I think we don't necessarily need to recreate the wheel unless absolutely necessary. So what is the framework that's currently available under the direct care registry? How can it expand? How quickly can it expand? You know, what is the cost required with that? And then what's the ongoing maintenance for that moving forward? And does the current registry make sense as opposed to creating something outside of that or doing some type of RFP? So those are the conversations that we have yet to move forward. Just a reminder, we don't have full approval from CMS yet on our spending plan, so we're waiting for that with bated breath. I think we're one of 40 states that are still waiting for that full approval, but we're hoping to get that very soon. We're very excited about this work. We think it's a really good opportunity for some of our individuals in the community to be more empowered and informed about how they choose caregivers, and that's an exciting thing.
Thank you, Director Matney. That was a great overview, and gives us something to look forward to. And I know there's a lot of work ahead, and I know there are a lot of interested parties and stakeholders in this initiative. I don't know if we want to move on. I know you don't have a lot of time and a very small window of opportunity, which I explained to folks. So does anybody have any questions for Director Matney in case she needs to jump off before we end?
One of the most, I'm just going to add one more thing, Ty. As we do have these conversations as well, we want to make sure that whatever mechanism we go down to create, you know, this job board or registry for our home and community-based members, that we do it with their input. And so bringing them in, you know, bringing them to the table to hear what are the pieces of information that are really helpful in making some of those care determinations and decisions, and like what are the types of formats that are best to see those in. So those are going to be important conversations, and we're trying to weave that in more and more into everything that we do. But I just wanted to put that out there too. We can, Di and Director Johnson are very smart people, and I'm super grateful to get to work with them. But at the end of the day, if we try to create this in a vacuum without that member engagement, we're probably not going to get as good of a solution as we could.
I would echo that. And I would say that maybe some of the challenges that we face today with the fragmentation of the system is because we have not had some of these key voices at the table. So thanks for that. Okay, well, I don't see any questions. Nobody's raising their hand, so I think we'll move on to for you, Director Johnson. And yeah, we've had a lot of long phone conversations, and thank you for that over the years. You've been very patient with me and our folks from our organization. So I'll just let you go ahead and you have a PowerPoint, right? Yeah, so do you want to, Pam can just make you co-host and then you can just do it, or do you want her to pull it up for you?
Can you see it?
Yep.
Okay, great. Well, good morning, everyone. It is a pleasure to be here, and Di, thank you for the invitation as well. Let's see. So first at DIA, we updated our website. And so hopefully it is far more user-friendly. If you go right to the front, I know a lot of the legislators, your constituents, probably would appreciate the second and third box up front. So I'm just going to spend just a couple minutes on the full functions of our database, which has two functions. But on the website, you can file a complaint and it will get directed to the right place. Most of the complaints we receive are health facilities, hospitals, nursing homes, and then restaurants. So that's right there. It's a very intuitive, simple form. So that way we can get right back in touch with you. The third box over here is records, excuse me. And it shows our two main databases we have as a department. And so that is the health facility reports as well as the direct care registry. And then underneath it is the restaurant and food inspections. So you can go straight there, as well as any open records requests. That information is right there. So that's on our website. We undertook updating our main database. Our database somehow got used as a website and it was very outdated. I think the first thing I saw on it when I used to go on it was a press release from 2003, which is not very helpful for constituents to find information. We had outdated broken links. So when you go to our database, it shows the two functions. It'll show the direct care worker registry and then the entity search. The entity search is what we call as facility report cards. The facility profile, you can search all DIA licensed and certified facilities. You have multiple ways to search. Facility name, you can just put part of the name, Iowa Veterans Home, you can just put veteran and it'll pull that up. You can search by county, licensure type as well. With the facility, there's a ton of information on it that is very helpful. You can contact information. It should have the administrator's information, contact phone number, the DIA contact information. So that's both for providers as well as constituents on what staff is really in charge of that facility. Facility self-reports that wouldn't be available to the public. Providers that do the self-reports, they would have login information. Members of the public would go to the main link on the main page. DIA visits, what are we there for? How often, how frequent? So all of the information we put every time we go into a facility, we put on that on the database that I think is a really good tool for members of the public, finding and finding and citation information. If there are deficient practices that require a state and or federal fines, we put that information as updated as we receive it. The types of survey, this is due in the last year and a half, the Focused Infection Control Survey. So you'll see FIC on the history of surveys, complaint, recertification, and revisit, and then the payment information. Providers, members of the public can run reports. I think anyone undergoing a major technology project knows the first goal is to get it functional, get it out the door, and then you fix minor bugs and then kind of beef it up, make it more robust. And so certainly we are in that process right now. If there were any migration issues, we currently are fixing them. And then there's some information. One example is Iowa code requires us to suspend fines for CMS to review it. Right now, if CMS is reviewing that fine, it shows $0. That's not really accurate. So we are going to update it to show, instead of the dollar amount, to show CMS review or CMS review pending. So that way members of the public know more accurately where something is in the process. So those are some examples that we currently are working on. Here you can kind of see the search function on the left. And I think we searched here hospice programs, so you can see all the hospice programs. I think there are 12 pages that this shows, the address, the county, and then you can navigate throughout there. When you go into a facility, this is a long-term care facility, so you can see the basic information, survey information, the number of beds, contact information. If it's a chain, any related entities, the DIA information. And then if you go over to visits, you can see all the types of surveys we have. Compliance, that's where the finding and citations, any deficiencies, and any payment information as well. So I think it's very user-friendly. We're still going to improve it, as Liz said. We try to gather feedback in the beginning. We continue to collect feedback now to make sure it is as user-friendly as possible. As Di mentioned, the federal requirement for direct care registry, it is a federal mandate on the state survey agency. That is what DIA is. We are a state survey agency on behalf of CMS for federally certified facilities that receive Medicare, Medicaid payment. And so who is placed on it? It's a CNA candidate that's completed the 75-hour course, passed the written and skills test. You can see they have to pass it within 3 attempts or have to take the course over again. And then there is a requirement that I think a lot of people find outdated, is that for our registry, that a CNA has to work in a long-term care facility for 8 consecutive hours every 2 years. So that is who is eligible for our registry. What do we maintain? This, I copied and pasted this information right out of the CFR. So the individual's name, information necessary to identify them, that they're eligible, and then also the abuse. We are charged with investigating dependent adult abuse in health facilities. So that is something that's very important that we maintain on there as well. So here again, the search, we have a lot of friendly searches that weren't available previously. And so you can search by county, name, city as well. And so you can see the list of Smith. That is what is available now. And then you can see the profile of the person. So the registry, the city, the county, and any employment history as well. So it is, as it's been previously stated, it is, bare bones on what information is. I would add that when you do a development, this is funded federally. We have 2 FTEs that fund this, and So while we may be limited with resources at the time for a full expansion, and that's what the group that IME is looking at to see how to grow it and what resources would be needed in the future to make it sustainable. But as far as technology, we did know these ideas and requests were pending. And so we wanted to make sure that our technology would be able to grow if it could. So that was just one portion because we didn't want to redo it or throw it out if DIA is the proper place to house this. That was a goal that we took into account in the development of it. That's all I had planned. Hopefully that is helpful. But again, I really appreciate the invitation to speak here today. So thank you very much.
No, that was great. And I think it just shows the complexity really of the issue, but it's encouraging to see that the two departments and other stakeholders having this conversation. And I do hope that we can all work together to move this forward. For us, it's great. It's great news. We do have, getting back to Director Matney's comments about the need to have direct care worker input. We do have 3 of our direct care council members on this morning. And I guess maybe before you jump off, I would just ask them, Fran, Cindy, Donna, do you have anything you want to add or mention to folks?
Well, I've been a direct care worker in the state of Iowa for like 32 years. I think it's just very important for me to say that we need a permanent and portable record of our training. It would be so great if every direct care worker in the state would be able to take their credentials with them wherever they go. It would make it so much easier for a direct care worker to move from one type of direct care setting or population to another. So it really is my hope that the barriers to portability could be removed, identified, and just dealt with. I think the current system is set up that direct care workers can become unemployable in some work settings. And so portability of our training would also allow me and other direct care workers to have opportunities to specialize in an area of their interest and their ability and their skill, what really fits with their character. Like, some are interested in Alzheimer's or hospice or mental health or brain injury or autism. Our credentials and training would also be validated and recognized rather than lose all credibility and come to mean nothing eventually. I have a 3-ring binder with me, and it's my portability of my credentials over 30 years. I have in there my CNA certificate, and I have all of the records of continuing education and training that I have received, that I've been recognized of having taken. But nobody else knows that but me. And within 2 years after I would be off long-term care, that means nothing. It comes to lose all credibility and means nothing. I would have to start over. So I just hope that the barriers to portability could be removed.
Thanks, Fran. Well said. Donna or Cindy, anything?
I agree
Yes.
with what Fran said a lot. It's just frustrating. I started out working in a nursing home, and then 2 years after doing that, I have been in home care, and now I'm a retired CNA now, but worked with hospice, and I'm not able to be on the registry since I haven't worked in a nursing home or anything. I've been an aide for around 40 years. And it's just kind of frustrating that all that work that you put into and how much you care about the profession that you chose, that you're not out there to be able to be recognized for that, and just makes it really hard. But I'd also like to thank the Director Matney and Director Johnson and the legislatures for all of your support, for backing us, and of course, Pam, and everybody. Why, really appreciate all of that also.
Thanks, Donna. Cindy, you got your hand up?
Yes, I did. Yeah, I guess I just want to agree with what they're saying. I worked 31 years in direct care as a CNA. I worked in facility, but I worked in a unit that was intermediate care for intellectually disabled the majority of that time. So I have credentials there and stuff, but the last 5 years that I worked was in community-based. Therefore, I lost my credentials because I was no longer in a nursing home. I guess my question is, how do we have to go through and get the law changed, or can it be changed in some other way so that that registry can expand and not be listed as by facility, but by individual?
So, Director Johnson, feel free to jump in. You're probably a little bit more familiar with the law. You know, I think we, from the Medicaid perspective, and I mean, first of all, thank you, Fran, Donna, Cindy, for all of your, years of service, and for those of you that have transitioned into the HCBS world, like, much appreciated. Like, this is such this is an area that I'm incredibly passionate about, and I know that those frontline workers are the backbone of it. I am not sure if legally we need to change anything, but from a Medicaid perspective, it's important for us when we're thinking about the solution, about how we're going to use that enhanced funding and align it, with our HCBS spending plan. Is it possible for that the framework that DIA has created for the direct care registry to expand into what we want to collect for our HCBS members, and all of the different things, like, is it possible structurally? What's the cost? What do we need to do from a legal perspective? And then that ongoing maintenance piece is also super critical. I know Larry has a limited number of folks that are working on this, and the more that we expand it out, the more that it might take to maintain it long term.
And just to add, I think there maybe are two issues. What Fran has suggested, I think, is something that we are looking at, or IME proposed to CMS. But Cindy, with regards to your question, it is a federal requirement that a CNA has to work for 8 consecutive hours every 24 months. And so that is a requirement of CNAs for long-term care. I do know our agency has brought that up for years now to the federal delegation, because that is a federal requirement that would require a change in the CFR. So those are two separate issues, I think, as far as portability, but the 8-hour requirement is a federal requirement.
And then just to piggyback on that, Larry, to the extent that we were to expand out this registry for direct care professionals in HCBS settings, it's not necessarily completely reliant on that CNA certification, right? You have other training requirements and education requirements and all of those things. So, if there was a way to split apart those different pieces so that, even if you're not serving as a CNA year over year, but you are providing these HCBS services, you remain on the registry. It's just denoted that maybe you don't meet that CNA requirement of the 8 hours per year.
Thank you. Thank you for those comments. Very, very helpful. And I guess I would just say before I see Senator Yoakum and Kelsey have their hands up, but is it safe to say then that the ARPA funding, one-time funding, I mean, this is a good use of those dollars because it can pay for the build out, some of the expansion work and the planning and so forth around that. But beyond that, there's going to need to be some other sources of revenue or other sources, other resources to maintain and sustain an expanded or modernization of the registry and inclusion of the direct care workforce, other caregivers, and that we still need to change the federal law when it comes to the 8-hour rule so that people are not deemed ineligible to work in nursing homes. That's something that we don't have the capacity to work on most of the time, but it is something that we've been trying. Like Director Johnson said, we have had conversations and asked for, waivers and all kinds of things, but have not been very successful in that area either. So maybe if we get enough voices around that, we can get it changed. But so I will move on to Senator Yoakum.
Thank you, Di. Hey, happy holidays, everybody, and thank you so much for organizing this. My question, it seems like forever ago now, but I know that Senator Reagan and I in the Senate had passed a bill that would have, that was recommended by you and your team, your work group, and this was probably almost, I don't know, 8 years ago now, but it really would have professionalized this occupation and would allow for that portability and to be able to move from different parts of that whole direct care work system. So here's my question. We passed it, went to the House, didn't even make it out of committee in the House, but anyway, the long-term care facilities just went at us ruthlessly after we passed that in the Senate. And I'm wondering if we have identified what their big concern was, because to me, this was a way to help solve their worker shortage and to be able to really professionalize and validate the valuable work that these workers do every day. And believe me, as a mom of a child who had a disability, I know how much that work is needed and expected and admired and needed. But Di, do you have any more input or conversation with long-term care facilities on where they're at today and if we have resolved some of their pushback from a few years ago?
Yeah, I don't think you were on yet, Senator Yoakum, when I said that we probably hold the record for work on this issue of about 15 years and that you and Senator Reagan also sponsored some version of this bill, back in the day. But in answer to your question, I think early on when we were proposing these kinds of things, there was, everybody, I mean, we are pretty siloed and people do get, I don't know if territorial is the right term to use, but we do all tend to do that sometimes. And the first question people have when you're proposing a piece of legislation or some systemic change is, how's it going to impact me and the work that I do? I think we've worked really hard the last several years in building a lot of bridges with different stakeholders in different communities. And if you go back and look at the list of groups that have signed on in support of this or neutral of this bill, I think it's pretty phenomenal how many people signed on even last year to Representative Bergen's bill. And so I think that just shows, talking to people, conversations, the nursing home industry, both Leading Age and Iowa Healthcare Association have registered, neutral monitoring the last several years on it. So I don't think they have any really key concerns about it. And probably if we were to have some more conversations now, they would be even more receptive to it again, just because of the challenges that they're facing in recruiting and keeping people in the field. But I would love to have, further this conversation with you.
Yep. No, thank you so much. That's helpful.
Kelsey, did you have comments?
Yes, my comments were right along the lines of Senator Yoakum's question. And I'm still kind of a newbie in the Senate, especially compared to Senator Yoakum and Reagan, but it just floors me sometimes when industry reps and their lobbyists don't register, or they say they're neutral. I think we should encourage them to register in favor, and then, tell their buddies in the lobby that they're really for this. Because they tend to move as a block, as a lobbying community. So if Republican leadership senses that the ABIs and the insurance industry is against it for any reason, they don't move the bill. And I think that's why you see it frozen sometimes. So I think we should really encourage them, tell them this is a win-win for everyone, and to have some courage and register for the bill. That's my input.
Thank you for that. And I think, yeah, I would agree. I mean, stakeholders need to work together, especially now. I mean, if ever there was a time that we should be placing a priority on this workforce, childcare workers too. I mean, a lot of parallels with childcare workers, and doing so in a bipartisan way. Now is the time. These should not be partisan issues, and we'll continue to have those conversations. But I think the good news is, based on the conversations we've had this morning, is that we don't have to try to pursue this bill during this next session because we are seeing some movement forward, and it can be done. I mean, at least the registry, that's only one piece of it. And I guess the other thing I would say, that this is one very complex and comprehensive piece of what we need to do, the registry expansion or modernization to build. I mean, it's foundational to building and supporting the direct care workforce. But beyond that, I know you all are going to be having conversations this next session about taxes and ways to enhance wages for this workforce. And I guess this is the other thing I would ask you all to consider when you start having those conversations, is to avoid thinking about the direct care workforce and we need to stop defining and paying this essential workforce based on the setting within which they work or the population they serve. That fragmentation of the system does an injustice to the workers and employers and all the stakeholders involved. I know it's a difficult thing to do because of different payment systems and Medicare, Medicaid, but I would just encourage you, when you start having those conversations, to step back and think of any unintended consequences if we're thinking only of raising wages for one subset of this direct care workforce and the consequences that could have on other subsets or segments of the direct care workforce. So I don't know if I don't know if that was truly a comment to yours, but yeah, I respect everything you've all said, and we'll continue to have conversations and work with you all and moving forward. And my final request, unless anybody else has their hand up or any burning issues that they would like to bring up for the good of the cause, I would just say I have one other request before we jump off, and that is for you all to have a very happy holiday. And we will see you sometime in January. Thank you,
Happy
everybody.
holidays. Thanks, Di.
Thank you.
Happy holidays.
Holidays.
Have a happy